Merci et bonjour tout le monde. Ça me fait plaisir d'être ici et surtout d'avoir entendu mention du nom de Michael Smith. Quand j'étais un jeune chercheur, Michael Smith était un héros pour moi, un pionnier, un homme tellement ouvert et qui avait toujours le temps d'être généreux avec des jeunes chercheurs qui voulaient discuter de leurs idées. Donc, je suis honorée d'être ici. J'aimerais aussi vous avertir que je vais garder du temps pour des questions. Je suis prof, on est habitué à avoir des défis. Je sais qu'il y a des jeunes, même des anciens de mes équipes, ici dans la salle, alors il ne faut pas hésiter. Il n'y a rien qui peut gêner un professeur, croyez-moi. So today's subject, you probably never heard of the right to science. It's actually shorthand, one that I don't really like, but shorthand for a very neglected human right, and that is the human right of all citizens to benefit from advances in science. So my goal, and I'll get there, it'll take me a little while, will be to elucidate this right and try to imagine how here we in Canada can take a leadership position in reactivating this dormant human right as a new way of doing science. So this is a diagram that comes from an article by Eric Schadt, and I think it best explains how in the area of human health and health under the broad definition of the World Health Organization, so not just the absence or presence of disease, but really human welfare, and all the different data points that enter into not only deciding who is at risk or resistant, who may or may not acquire certain conditions, but also the total picture, or the contextual picture of the health, of determinants of health. I recently had the pleasure of working in an FP7 project in Europe on geospatial, combining geospatial data with data from biobanks and what the ethical and social and legal issues could be. And I was quite surprised at how the combination of different technologies allow us to better predict and thus better prevent and disease, but also to promote human health. And I think it aptly illustrates stress of traffic, cell phones, airplanes, which I spend too much time on, and climatic conditions and so on. So there's a broad source, or many sources then for big data. And I think when we talk about genotype, it's only a map. It's not even a precise location. That's why we're trying to go from genome to phenotype, which is the expression or the elicitation of the expression of the genotype in every individual. It's called phenotype. And to get there, we need to have big data. And I'll try to illustrate, using cancer as an example, since I work with a lot of people in cancer, how we think that using big data may, you always have to have caveats, not because I'm a lawyer, but just because I'm a professor and we always think there's always things that we don't know that we still need to study, may help us get to personalized medicine. It is my contention that we are not going to get to personalized medicine unless, and especially the potential of the genome mapping effort and now the disease location on that map, unless we use big data. And the reason is that there's a missing step, what we call stratification. So as we go from big data on whole populations or areas of the world, to get to the medical part, the real treatment part, the personal part, we need to start dividing into subpopulations of risk or resistance. We keep talking about disease, but we're all here in this room, so there's health as well, which we should look at. Why are some people healthy? Why is there a project called the Healthy Obese, an FP6 project in Europe? People that their BMI is way off the map, but they're healthier and exercising and being effective and productive citizens, whereas they shouldn't be according to the standards. So as we go down into stratification into subpopulations, we will also be able not only to offer targeted therapies and prevention and so on, but also to understand the fact that we will be regroup differently for different things. So I'll be at risk for this, but I'll be resistant to that. I'll be at 10% for this, but 80 for that. And hopefully, these new regroupings of individuals will break apart the traditional discriminatory categories, which until now have sort of led to untoward effects in insurance, employment, and so on. In other words, by normalizing through different regroupings of subpopulations of risk and resistance, we can start talking about like the weather, in probabilities. And we can no longer be said, oh, she comes from that area, she's going to get this, or he's from that family with that family history, he's going to get that. And the meaning of that medical data will no longer be like a sort of a predestination in terms of your conditions. And so insurance companies are going to have to start throwing out their actuarial tables and so on and reconfiguring. And even better, our universal healthcare systems, of which we Canadians are so proud. In fact, I think it's a unifying social value across Canada, will be able to be sustainable, which they no longer are right now, because we can target resources effectively where they're needed and not try to offer everything to everybody, whereas 3/4 of people don't need certain things and the other quarter really needs much more. So that's one of my idealistic ideas on the use of big data to get us to personalized medicine. But we need tons and tons of samples and data. Take the UK Biobank. It has 500,000 citizens enrolled. In order to get a cohort in that 500,000 person data bank of, let's say, 10,000 women between 35, 45 with a certain kind of breast cancer, let's just say BRCA1, BRCA2, it would take 13 years for the UK Biobank to have sufficient data to give it to you. Whereas if the UK Biobank was interoperable with other biobanks around the world, in other words, they had data sets that weren't exactly standardized, but at least harmonized to the point where they could be shared, I, as a researcher, could go and get my cohort of 10,000 women today. And there are efforts around to do that in order to have that kind of sharing between different countries of data, so you get the big data that you need to answer the research questions that are so important. We know that everything works in silos. Nothing is worse than the university, even if they say that they want to promote multidisciplinarity and all that sort of stuff. It's very hard for our young students who do dare become broader students in terms of crossing disciplines and so on. We know that for research it works for silos. We also know that for grants it often works in silos. We know that our analysis methods are non-standardized, and that's where standardization should come in. And we know that in terms of regulation and laws, Canada's like a little Europe. I mean, you just take privacy legislation across Canada. You might as well just take 10 European countries, and you've got the same issues facing you in terms of sharing data, even within a country under research programs that are Canadian funded. I will not even go into electronic medical records. So I'm going into the clouds. So the clouds is where the action is, if I can put it that way. And I've got some stories to tell on clouds if I have time, but let's just stay with this for now in terms of how researchers now, particularly in genetics, are increasingly turning to the cloud, not only as a storage environment, but as a computing environment as we move into petabytes of data. This comes from the pan-cancer analysis of whole genomes, and it's a very good illustration, I think, of the contrast. This is only about data that's about 8 months old between the traditional way of collaboration between 10 academic data centers, the number of samples that are needed, the number of dollars that it costs, the number of patients, 30 that would benefit, and the time that it takes compared to the cloud on the right. So, as they say in first-year law, res ipsa loquitur, the thing speaks for itself. But there's also a lot of hype. By the way, if you ever are looking for cloud pictures, there's really funny ones. I mean, there's one that says something like, but what happens when it rains? I didn't put that one up because I know this is a very erudite audience, but there's a lot of confusion and misconceptions about clouds, but also a lot of hope. Yet, I've had the pleasure, in quotation marks, of speaking to lawyers of some of the biggest companies, the big cloud companies, not to be mentioned, they're well known, and the kind of studies that we want to do that would combine health data with social data, looking at their cloud service provider contracts. You can just go on the web, you can see them. The clauses are standardized. The clauses are what we call boilerplate clauses. So when you call them up and say, well, by the way, most countries' health data is sensitive data by law. I consider it normal data, but the law considers it sensitive data. And they said, no worry, no worry. And I said, well, yes, because I won't get it through my ethics committee if I say I'm using a cloud provider if certain conditions aren't met. Oh, well, that's just take it or leave it. Because remember, they have the power, huh? They have the, and then, well, no, we can't not do it. Well, we could tell you that economic data is even more sensitive. We could bring down whole economies, and the banks have accepted these clauses. So that's the kind of conversation. They're not yet with it. There's a great interest in health as the new sort of future that they can build as these big companies in terms of computation of health data, but they haven't quite linked in yet to some of the sensitivities and the particular concerns that citizens have, especially following NSA and Snowden, and as well as the fact that there's sensitivities in Europe, for instance, to data going outside of the European Union, and so on. I was told in yesterday's Wall Street Journal that today is the day that the European Union is going to announce their data protection regulations, something they've been working on for quite a number of years. They have the Data Protection Directive from 1995, which, as you know, led to the creation of a safe harbor agreement with the United States in order to make sure that equivalent protections could be offered to European data going to the United States and vice versa. That safe harbor agreement, as you know, was declared invalid 3 months ago. So we're in a very precarious situation of ongoing collaboration between Europe and the United States. But Canada gets somehow thrown in. I keep telling them, but we're adequate, we're safe, we're not we are considered adequate by the European Union Working Party 29 in terms of data protection. But never mind all that, this new regulation going into effect is a regulation, not a directive, which means by law, it becomes law in the countries, European countries of the European Union. A directive allows you to interpret in your legislation according to your own cultural, political norms and so on. A regulation is like, sockets in the wall and that kind of thing. You have to follow the regulations. So 1, it's stricter. 2, if you've bothered to read through the ups and downs and ins and outs of this regulation, it's conservative, it's protectionist, and it comes at a time when we need more data sharing, not less. So we'll wait to see. Probably later today, there'll be an announcement on what happens to research in that new regulation and what happens to international data sharing under that new regulation. It isn't as bad as it was 6 months ago. I'll limit myself to that for now. And we will find out at the end of January if they've been able to come up with a new safe harbor agreement between the United States and the European Union. What we're doing or trying to do here, this is an article with Lincoln, I wrote with Lincoln Stein and others, is to create this notion of a cloud commons. We heard about the CFI being about infrastructure, and I'm a real proponent of having discovery science working together with infrastructure science. And part of infrastructure science, as we just heard, and finally the CFI has come into this, is the whole cyber world, the sharing of data, the tools that you need, the management that it requires, and so on. And being able to put this together and make it accessible to others. There's no sense using taxpayers' dollars and hiding it somewhere. Data has to be free. Data has to be available. So what we want to create is a bit like the Human Genome Project that was talked about, is this idea that whereas data has to be secure and in certain cases with different levels of privacy, that this data should be part of an intellectual commons, a genomic commons, where the rules are well known, where the data is secure, and that everyone can share in such a commons. And one example that we're building is the Cancer Genome Collaboratory. And this is an effort led by Lincoln Stein from OICR with other colleagues and so on to build the techniques needed to allow large data sets as we move from the International Cancer Genome Consortium to the International Cancer Genome Medical Consortium, combining genomic now with clinical medical data to get towards contextualization in the actual clinical environment. So to take the science and move it to the diagnostic and treatment arena. But we know that we lack capacity and the compute power and so on and so on. Hence the dealings with these big multinationals. So we can address these issues, but privacy and security concerns remain. We're constantly trying to think of everything that might go wrong, could go wrong, or may go wrong in order to put in the tools and security structures without defeating the very purpose, which is our purpose, is to make data open and accessible. So anyone in this audience that knows me knows I'm the least techie person. I don't have any of these things, but let's go to how are we going then to activate this cloud commons, and how are we going to really create a way that big data will serve the people it describes? Well, in 2013, January 28th, 50 people met in a snowy storm in New York, 25 of whom were involved in the original Human Genome Project of the 1990s to map the sequence map, the Human Genome Sequence Map, and said, what's next? What do we need to do next to make this map valuable? So we created the Global Alliance for Genomics in Health. It's an alliance. It's not incorporated. It doesn't exist. It's actually a coalition of the volunteers, of willing people who want to have a framework for harmonized approaches to catalyzing data sharing and to demonstrate the value of data sharing. So it convenes, it catalyzes, it creates, it acts as a sort of clearinghouse for data, fostering innovation, and just people working together because they have an idea. It does not generate or store. It does not fund research. It has no money. And it does not interpret genomes. But it's open to all entities, and there's one condition, which I'll say in a few minutes, even those who do not commit to sharing data. We sort of feel they'll get the message and they'll eventually convert, but we don't say you're not allowed in, okay? So we want to work internationally. Absolute goal is to make to involve South America, the African continent. Obviously, Asia is very heavily involved for interoperability, harmonization, while respecting individual choice. And so mainly it's just there to support as much as it can through brain power of the people that decide to join the alliance and engage professional communities and the public. We haven't quite got to the third level yet. Right now we're at, as of yesterday, 375 organizations. And you can see I didn't put individual members down. You can see the breakdown is interesting. It's university, obviously, academic, disease groups, consortia, funders, and life science technology companies. So it's a good and across 36 countries. There are 4 working groups. These are sort of like steering groups for data, for clinical, regulatory and ethics, which I'll concentrate on in a few minutes, and the security working group. We meet when we can at other meetings. Whoever has money that can travel goes. As I said, there is no funding for this except for secretarial. Administrative headquarters are at the OICR in Toronto, so very proud Canadian headquarters. And the clinical is in Boston, supported by the Broad, which just means secretarial administrative support. The regulatory is at McGill University in my center, and the security group is in California. I have a co-chair, Kazuto Kato, and we have 13 members in our group. all from 13 different countries and over 200 people on our teleconferences, our monthly teleconferences who join. Now this is, if you want to become a member, you have to sign up to the Framework for Responsible Sharing of Genomic and Health-Related Data. But we wanted to do something different here. And what's different here is that I've been, as was told, in this policy arena for a number of years. And it's always what I call the Nuremberg legacy. It's always sort of, as a scientist has to come in front of an ethics committee or a privacy commission and say, I've done all of these things to protect participants. In other words, there's almost a burden of proof that has to be, what we call a reversible burden of proof, to show you're not going to harm. And this has permeated all our guidelines, our laws, everything, rather than seeing ethics or law as a facilitator of good, responsible science. It's seen actually as a sort of a pushback, if not a total barrier. What we want to do is to flip all this around and instead use a human rights approach. And I'll describe that to you now. I've been teaching for a long time. I'm not an international law professor, but I do remember reading the Universal Declaration of Human Rights. But I could remember that everyone was equal in dignity and human rights. That's the article I remember. But hidden in that declaration was this Article 27.1. Everyone has the right to share in scientific advancement and its benefits. And in that same article, but I won't go into this today because it's another whole hour, scientists have the right to the protection of their moral and material interests from anything in which they are authors. So you have, on the one hand, the right of citizens to benefit and the right of scientists, including our curators, our annotators, and so on, to be recognized for their work. So there's IP in the same time as you have a right of citizens to benefit, all in one article, lying there, hidden away, till about 2009. What happened is that in 1966, again, unbeknownst to me, the International Covenant on Economic, Social, and Cultural Rights took that same Article 27, paragraphs 1 and 2, and took it and put in Article 15. Now, what's different about a covenant is that if you sign as a country and you ratify, you're stuck, you're in, it governs, which means it's an actionable human right. So a declaration is aspirational. It can become part of customary law, but a covenant that is signed and ratified means that citizens can put their governments to task and say, have you committed to this? What are you doing about it? And so you're bound to implement. It's universal, it has international legal force, and it also belongs to groups, not just to individuals, and imposes positive duties. So this is a totally different way of thinking about science. And we can build on the case law that already exists and the legislation on traditional concepts surrounding science, such as privacy, anti-discrimination, fair access, and procedural fairness. But we have never thought of our guidelines, policies, and laws actually trying to activate this concept. The framework has been translated by volunteers into 11 languages. It's short, very important, clear and simple, even more important, because scientists need to be able to have this in their own language. It's high level, but it's enough to get you into the mindset, if you like, of the Global Alliance. And we've started working on more practical parts, such as a first thing everybody wanted in 2014, March 2014 at a meeting, everyone wanted consent clauses. And I understand why. You look at a consent, it says nothing about sending samples or data outside of the country. Uh-oh, no can do. Your ethics committee will say no, there's no consent. It says nothing that one day maybe somewhere we'll commercialize it, make a product, make a device, do something, a pill, something that'll help. You didn't mention commercialization. So we needed some of these generic clauses that researchers need, and you don't talk about security mechanisms or privacy or whatever. So we did the clauses, we did a policy for consent, but I have to say, this is the one area, I think the regulation will settle this because they actually do allow for broad consent, the new regulation coming in later today in Europe. We had a room, we had 3 hours, I think we spent 2 hours and 52 minutes on consent. Because somebody would say, in my country, and then someone else would say, yes, but in my country. So finally we decided in the framework there was no way we were going to come to a common consensus on what kind of consent would meet the goals of the framework. So we said, presuming legitimate consent has been obtained, comma, and we went on. And we just said, you handle it in your own country, start moving towards broad consent, because only broad consent for future unspecified biomedical research as approved, it's not floating out there, as approved by an ethics committee is what we need for data sharing. So when your country gets there, it gets there. But it's interesting that we almost came to a complete standstill. We just finished privacy and security in September of this year, have the attributes for what we call data safe havens, and the accountability policy will go up next week and be open for comment as well. And I'll come back to some unique features of these policies that make them different. So the aims, obviously, are data sharing specific. And the other big discussion that we had was the foundational principles. Why? Because like here in Ottawa, and any place where you have like sort of a legislature or a House of Commons or a group coming together, people want their particular focus in there. So take the first foundational, promote health, well-being, distribution of benefits, or respect individuals, families, communities. We have to add this, we have to add gender, we have to add disabled, we have to add, indigenous peoples, we have to add. We said, well, wait a minute, this becomes a list, and what if something is not on the list, or then changes terms and becomes politically correct and becomes something else, and then your list is, you're finished politically, because why can't we just say individuals, families, communities, and let you interpret in your local context what that means and where your priorities are, where your concerns are, and where your focus should be. So the hardest part we had was keeping it short and simple, and yet universal enough to cross different countries. The core elements are in there. Each of them has 3 procedural points. That's it. No long paragraphs, whereas, or any of that stuff. So it's actually handy, readable, and hopefully user-friendly, but does remind people of 3 aspects that they should keep in mind. So this is still the framework, it's still very high level. So the consent policy, the first one that came out, presuming you have obtained a legitimate consent. The one that we had the most problems with was the legacy data. This is an endemic, it's not limited to Canada, but I can remember one project, and I won't say which university in Canada, where we wanted to access the medical files of 10,000 women who had died of breast cancer, and 10,000 women in another group who had taken tamoxifen, who would have the same, data points and so on, compare them to sort of, we couldn't do it because the 10,000 dead women had not consented before they died. And that's what set me off in a real, not tirade, but close. The families of those women were furious that because they had not signed, what are we, notaries here? I mean, what is happening with research that we have to, go right down to and put initials at the bottom of every page like we're selling property or something. And so we now are trying to say broad consent for future unspecified medical research as approved. Because there was no way, if you only say breast, I once had to reconsent to another group because it was breast cancer, the women were still contactable, but the ovaries weren't mentioned on the consent form, and now we wanted to use, so you can see where I'm going with this. So we now, in the sharing of legacy data, have given 3 possibilities for you can go to an ethics committee and either do 1, 2, or 3. Obviously, recontact and reconsent is one of the 3, but in most cases, this is beyond the capacity and financing of most biomedical research, or it's not practical either. Okay, privacy and security. This was fun. I learned a lot about computers and security and the rest of it. But the most important part of this policy was proportionality. Now, our Canadian TCPS guidelines talk about a proportionate approach. in Europe, proportionality is a principle. It means don't put the most awful case scenario, you know, the worst risks that can happen, the what if one day somewhere, someone does something as your standard, because nothing will get